introduce Dr. Ayesha Mahmud. Dr. Ayesha Mahmud is an assistant professor at the Department of Demography in Berkeley, in the University of California at Berkeley, where she studies the interplay between population mobility, environmental factors, and disease dynamics. She received her PhD from Princeton University, and her dissertation examined the social, demographic, and environmental drivers of the transmission dynamics and mortality of common childhood diseases. And she was also a Rockefeller Foundation Planetary Health Fellow at Harvard University, where she studied the interaction between climatic changes and demographic shifts and the consequences of this interaction on the transmission of infectious diseases. Today, she is using statistical models and biologically mechanistic models to answer questions related to the context of development of multiple diseases in countries in Asia, Africa, and Central America. And she used a wide variety of data originating from disease surveillance systems, hospital databases, human mobility data, climate models, and population surveys and census. So with this, I invite Dr. Ayesha Mahmud to share with us some of her exciting research.
Thank you so much, Anas, and thank you for the science update. I think that's such a brilliant model. You do this every month or every week?
Yes, so this is the idea of the consortium, is to have these updates every week. So yes,
that's really nice.
We used to do it many 3 times per week, but yes.
Wow.
I think others know better than me. So
I mean, I have such a hard time keeping up with the literature, so this seems like a very nice model. Anyways, thank you so much for having me. I'm very excited to present. Let me try to make this work. Share my desktop. Okay. Full screen. Oops, is that working?
Yes.
See the slides? Okay, great. Thank you so much. So I, as Anas mentioned, I mostly work on, understanding infectious diseases in the context of low and middle income countries. But today I thought I'd talk about some work we've been doing in the US since the start of the pandemic. And really, I think it started off as primarily a data collection effort and not really a modeling effort, but a few modeling studies have sort of evolved from the attempts to collect this data. And this project is with a close collaborator at Berkeley, Dennis Feehan, who's also in the Department of Demography. And Dennis and I really, at the start of the outbreak, Dennis does survey research. We just were trying to brainstorm what we could do, and so this is sort of what evolved from those early conversations. And then I'll present some work from some brilliant grad students who've essentially taken the data we've collected and done some modeling work. Primarily, I'll present some work from Taylor Chin, who's a graduate student at Harvard, and also 2 other graduate students from Berkeley, Casey Breen and Ethan Rubinoff. And some of this work is jointly with Caroline Buckey at Harvard. So I'm going to be talking about how we've been attempting to understand interpersonal contact in the US and why that has been important in shaping the outbreak dynamics. Okay. Oops. Okay. So why do we care about contacts? Well, I think this group, I probably don't need to spend a lot of time in explaining why we care about interpersonal contact patterns, but the main idea is in a lot of this, especially the SIR modeling framework, how it's traditionally set up, we assume this mass action homogeneous mixing. So the population is evenly mixed. And for respiratory pathogens, so for influenza, measles, COVID, SARS-CoV-2, and things like that, we care about person-to-person contact. So this could be conversational contact, it could be physical contact, and we actually measure both in our survey. But the idea is there's social structures and spatial and physical structures that are moving populations away from mass action, and these affect how diseases spread in human populations. And the bottom here is some data from sort of the landmark study measuring social contact. So this is really one of the first large-scale studies, the Polymod study in Europe. I think you're probably all familiar, so I won't spend time on this. But the way they measured social contact was along the lines of age primarily. So in many ways, age captures many of the important sort of social structures. So things like schooling and workplace, and sort of, I'm a demographer, I think about age and life course events all the time, but age is a very good proxy for measuring how society structures human population. And so there's very distinct patterns when we look at age-specific contact rates. So these are contact matrices for 4 of the countries in Polymod at the bottom. And what we're plotting here, or what Masong et al. Are plotting here, is the age of participant on the x-axis and the age of contact on the y-axis. And this is really what many modelers use as direct inputs into their mathematical models, where they have different age compartments and they need to know something about the level of contact between these age compartments. And so we see in the Polymod study this very clear signature. I don't know if you can you see my mouse? Is that helpful? Okay. So we see this very clear diagonal pattern where people generally tend to mix with people in their own ages. And then we see some of these off diagonal trends where we see parents mixing with children, we see grandparents mixing with grandchildren, and so this pattern actually has been seen in many countries now. So the Polymod study was one of the largest ones, but since then there's been studies all over the world. There's been studies in several studies in the UK, and also over the course of the pandemic, there's been several studies in the UK looking at this. But there's been studies now in many low and middle income countries as well, including Uganda, Zimbabwe, India, and many other places. And when the pandemic started, what sort of, I was having a conversation with Dennis, and I explained to him that we really don't have great data on this for the US, which is somewhat surprising. And we actually started, when we were trying to get this project going, we were applying for some funding. And one of the things we did, we sort of did a very quick search of mathematical models in the US that are age structured to see what data is going in, because this is the sort of the basic data that you need for any age structured SIR type framework, or even an agent-based model or a network where you have age groups. So many of those studies, are still using data from the Polymod, and the most common approach is to take data from the Polymod, use the demographics of the US to model what the Polymod contact pattern would look like in the US, and then apply that directly into the model. And I think in most cases that works reasonably well, but during the pandemic, where contact patterns are changing a lot, they're really relying on Polymod, which is based in European countries more than 10 years ago now, seemed to us slightly problematic. So that was sort of how this project started, and the reason that we started collecting the data. And there's been several studies that have done this since the start of the pandemic. So this is a really great paper by Zhang et al. It was published in Science, looking at these contact matrices from a baseline period in Wuhan and in Shanghai, and then looking at what these contact patterns looked like during the outbreak. And you can see this dramatic drop once lockdown is announced. And clearly contact patterns are changing, not just in terms of the reduction in levels. So the lighter colors indicate it's a lower level average number of contact, but there's also some shifts in some of these patterns, where there's this hollowing out of contact amongst children, for example, and some other interesting patterns that emerge. And they go on to show that really shaped what the early dynamics looked like in both Wuhan and Shanghai. So we started the Berkeley Interpersonal Contact Study, the big study, in March of 2020. So our first wave, which is sort of our pilot wave, was started on March 22nd. So we were, the survey has changed quite a bit actually since March, because when we started in March, we were scrambling to get the funding and to get the survey going, and the lockdown had just been announced in the Bay Area, at least. And this, what we have been doing is using an online panel. This is called Lucid. There's many different online panel providers. This is the one that sort of Berkeley researchers have most commonly used. But this is a sort of a non-probabilistic quota sample, and what that means is they have a very large panel of opt-in users, and they try to match the demographics of the U.S. populations, and so we've been using these online panels, and then sort of our hope is to now try and move into doing more sort of address-based probabilistic sampling to give us some understanding of biases that might exist in online data. So I won't go into too much detail about what this online data might mean for what we're measuring, but we can definitely talk about that in the discussion. So what have we been doing? We've been asking people about their average number of contacts on the previous day. And we define contacts in two ways. It can be a sort of a direct contact, conversational contact, or a physical contact. We ask respondents to specify what kind of contact it is. And then we ask a whole host of demographic questions. We ask about age, specifically because we're interested in these age contact matrices, but we also ask about race and ethnicity, employment status, and if they're an essential worker. As I mentioned, the survey has evolved quite a bit, and we've had other researchers join in and add questions. So we've been in more recent waves asking about vaccination status and things like that. So I'm showing here data from the first 6 waves. We called the first wave, wave 0, hence wave 0 to 5. I know that's confusing. But this is data from the first 6 waves. We're actually, I think, now on wave 9. So we've actually continued collecting this data roughly about every 6 weeks or so. We're not always quite right on the timing, but roughly 6 weeks or so. And then each of our samples, our full samples, we started off around 1,500 for the pilot, but since then we've been averaging around 3,000 respondents per wave, and it's split in 2 ways. So we have a nationally representative sample, so the quotas are matched to the demographics of the entire US population, and then we have several city-specific samples. And the reason for this is we had some collaborators in various places in the Bay Area, in Boston, who wanted these city-specific samples, and so we've sort of added some of these cities. So Philadelphia, we didn't have in the first wave, but we had someone in the health department reach out to us, and so we then added started adding Philadelphia as well. The city samples, I'll show some results from those. They're a little, the definition of a city is something that is a little different from what we might think about it. It's defined by Lucid. It's sort of a marketing term. I think it's called a DMA, which is sort of a marketing advertising area, but basically it's a city plus a little bit around the city. So those are our city-specific samples, and we ask the same questions to both our national sample and the city-specific sample. So we've seen some interesting things in the data. So one of the first things we did is just sort of look at the very simple descriptives of what's happening to contacts in the US. And we actually were lucky in that we had some baseline data from a survey that was done in 2017 by Dennis Feehan, my collaborator, and he was measuring something completely different, but he happened to ask people about how many contacts they have on a daily basis, and he actually happened to also ask about the age of both the ego and the respondent. And so we were actually able to compare the data we were collecting over the course of the pandemic with previous data. So the first column here is showing our contact matrices in the BIGS data. So this is the wave 0, our March wave, and going forward in time up until September. So this is the first 4 waves. And then this second column is sort of showing the difference between the baseline, but it's actually a little bit easier to see in this last column where the light blue is showing the number of contacts reported in the baseline. And you can see for some age groups, it's actually quite high. And this is usually people of working age, where on average, they're having roughly 12 contacts per day, which sort of makes sense if you think about sort of a work setting. Unfortunately, we were missing children in the baseline data, so we couldn't compare. And I should also note that the youngest age group, we didn't collect data on them for most of the initial rounds, because that's sort of a additional IRB hurdle that when we wanted to get this out the door by March, we didn't. But this is something that now we're asking parents to report on contacts about their children. But this initial waves, the way we're filling in this very first cell, the 0 to 18 mixing with the 0 to 18, is actually doing something similar to what I just described, taking the polymod, removing school contacts because schools were closed for most of this period, and then adjusting it to the demographics of the US population for the 0 to 18 group. So this is sort of a model based estimate for the very first cell, but we're hoping we can fill that in with our data. There's actually a really great study happening based in Berkeley, measuring specifically school level contacts by Justin Remay and his team. And so we've been in conversation about sort of merging the two data sets as well. So what we essentially see is that when the lockdown was announced in the US, we see this very dramatic drop in contacts across all ages. And then slowly over time, we start to see these contact rates creep up. And we actually also asked people about where they were having their contacts. And it really sort of the data kind of reflects what we might expect. So each dot here is representing a different survey wave. So the pink is the latest survey wave. You can see, for example, when we ask people about the average number of contacts and who they're having these contacts with, work contacts really starts to go up as we move forward in time, which is really sort of what we would expect. We also see that people start to mix more with friends. And this is sort of like fatigue with lockdown and such, because even during these periods there was lockdown, but you can see that increasingly over time there's more mixing with friends and family. And also when we ask about the location of contacts, we see that there's more increase in work contacts and also meeting in people's homes and a little bit in bars and restaurants and so on. School contacts remain low until we look at much sort of later waves when schools went back to in person. And we did in our very first pass of this, the modeling approach we took was a very simple approach where we assume, similar to what has been done with the polymod study and other studies, we assume that this age structured contact matrix is directly proportional to the next generation matrix. And so that gives us a nice way to get estimates of R0 if we just look at the dominant eigenvalue of the matrix. So all we're doing here is taking our contact matrix, assuming it's proportional to the next generation matrix, and then comparing this dominant eigenvalue to the dominant eigenvalue of our baseline contact matrix. So the survey from Dennis Feehan in 2017. And we can use that to get a relative estimate of what we think is happening to R0 over time based on our contact data. And this is really just a pure reflection of what we see if we just look at the average number of contacts. And so if we assume a baseline R0 in the absence of physical distancing to be around 2.5 or having a mean of 2.5, you can see that in wave 0, this is in March, sort of mid to late March, this dramatic drop in R0, but slowly over time, we see it start to creep up. And maybe I should pause. Are there questions? I can take questions of this. Or should I keep going, Spencer?
Ayesha, on the last slide, I had a question.
Yeah.
What is the difference between the kind of blue and red estimates? It says relative to Facebook or polymod?
Yeah. That's a very good question. So we did a few things here. So initially when we did this, we just looked at it relative to relative to looking at the data from the 2017 baseline contact survey. But we also were sort of interested in if we assumed that the baseline was, this is FB, this blue line is actually, this is a little bit confusing. So when I say baseline, this black dot, all I mean is just this bit. This is just what we assume R naught to be in the absence of any physical distancing. Okay, so this is just taken from literature. We assume it has a normal distribution with mean at 2.5, and we specify a standard deviation. And then what we did is this blue dot is our baseline face. So it's FB because it was actually a Facebook. So Dennis Fehan used to work at Facebook for briefly, and he did this original 2017 survey while he was a postdoc there. And so that's why we're calling it the Facebook study for better or for worse. So the blue is when we assume that baseline contact patterns in the US looked like what Dennis measured in his Facebook survey, his initial sort of baseline Facebook survey. When we submitted this, reviewers came back to us and asked, well, polymod is sort of the gold standard. And so what happens if you assume that the US population looked like sort of polymod adjusted to US demographics in the baseline? And so we did the exact same calculation, but switching out our Facebook contact matrix with the polymod for the baseline. Is that helpful?
Yep, thanks.
Yeah. And then I should say we also did another version of this that's in the paper, but I'm not presenting here, is where we and this is also a great comment that we got back from a reviewer, is that we did ask about mask usage. And so one of the questions is, well, if some of these conversational contacts are happening while you're wearing a mask, well, that probably reduces risk of transmission. That's not really being reflected in this sort of naive R naught estimate. And so one of the things we did is we removed contacts where the respondent was wearing a mask. And that assumption is essentially sort of the other end of the spectrum. So that's assuming that if a contact happens while someone is wearing the mask and both the respondent and their contact are wearing masks, that there's no transmission. So the masks are perfectly effective. So we want to get a sense of the range of R naught values. And what we see is we still see this sort of U-shaped pattern, but this increase is much slower. So if we have this, I apologize, I didn't put this here, but it's a much slower increase, which suggests that over time, people were using masks more and more. And so as we keep removing those contacts from our model, we don't see as sharp an increase in R naught. So mask usage, suggests that it sort of helped mediate some of this rapid rise in contacts that we actually saw. So that was sort of another interesting finding. So one of the other questions we were interested in is thinking about how these contact patterns differ by various demographic and other characteristics. So this is a very simple negative binomial regression model where we're just predicting the number of non-household contacts. So household contacts, we think probably have different predictors than non-household contacts. So we look at both in the model, but we look at them separately. So here we're predicting the average number of non-household contacts based on coefficients from a binomial regression model. And we can see that there is some variation. So weekday, weekend really didn't seem to make much of a difference. And this might, we haven't repeated this for the later waves. I think this is primarily sort of at the height of the log run. The first 4 rounds were all when things were very much closed down. And so, it's perhaps not surprising that we don't see much of a day of week effect, even though this is sort of, especially in the polymod study, we did see a pretty strong difference between weekday and weekend. We see some difference by household size, but I think the sort of race ethnicity differences are interesting, but the story is not, at least in our opinion, sort of clear cut, because there's a lot of difference by wave. So here, again, the pink is the latest wave, the green is the earliest survey wave. And you can see that over time contacts are increasing for all demographic groups, but not in the same way. So initially, all racial and ethnic groups reported pretty low contacts across the board. So green in our wave 0 of the data, and then we see a sort of jump up for Blacks, especially compared to whites and Hispanics and other non-Hispanics. But sort of if you look at the white contact pattern, it sort of increases much more rapidly in the later rounds. So I think there's a lot more digging into this that we can do. This was sort of a first pass of trying to understand sort of differences by race and ethnicity, particularly when thinking about sort of essential workers and who's in those jobs and sort of who's able to socially distance and not. We actually also include in our survey the specifically ask people if they feel that they are able to socially distance themselves. And we see that non-Hispanic Blacks and Hispanics are much more likely to respond that they don't feel that they can adequately socially distance themselves. And then when we ask for the reason, it's primarily because of work-related reasons. So we sort of see this narrative that we've been seeing and talking about sort of in the media and other places. We sort of see that kind of reflected in our data as well. And then we see a gender differential. Males seem to have more contacts across all ages. We see more contacts slightly in the younger age groups compared to, say, the 65 to 100. I'll talk a little bit about that in just a minute. And then our national sample compared to our city-specific samples is really not a lot to say. We see Atlanta is a little bit of an outlier. New York is a little bit of an outlier in the very final wave of the data collection. But you can see in the first wave at the height of the lockdown, this green circles there, it's sort of low across the board. So I'm going to talk a little bit about more the sort of age-specific contact and some work that Taylor Chin, who's a really great grad student working with us on this, has been looking at, and this is very much work in progress, and so we would sort of welcome any feedback you would have. So what Taylor's been doing is looking at the city-specific samples, and she was sort of interested, if I go back one slide, in this question of this age-specific changes in contacts and how that's been changing over time, specifically if we look at different cities. So this is looking at each of our city samples. On the top panel here, it's just the average and the median number of contacts over time. So this is data from 6 survey waves. So the red is showing median contacts. This sort of reflects what we see in the national sample that's going up. And then it actually goes down again in the fall. Sort of, there's some places experienced a fall wave leading to sort of stricter lockdown restrictions in 2020. And so we see this decline. And then closer to winter in some places, we see a slight increase. So there's some variation across places as well. And we've made some attempt to match this with when different lockdowns are put in place and taken off and sort of those rules. And that's still very much a work in progress. And then we also see this median income, and actually we see a pretty big difference between the mean and median, which means our distribution is quite skewed. And I think that's sort of interesting in terms of, if you look at this number of contacts, people reporting more than 20 contacts, you can see that really as we go forward in time, so the x-axis in each of these plots is going forward in time, you can see that people start reporting more of these higher number of contacts. So it's sort of a skewed distribution, and that most people are on average reporting 5 or 6 contacts, but going forward in time, we see more and more people who are reporting these larger number of contacts. And there's some variation. So you can see here in New York, there was, this is, I think, just after the summer, there was a lot more contact sort of as things opened up a little bit, and then things closed down a little bit with fall waves in various places. And so Taylor was interested in this question of what's happening to the different age groups, and what we see is that mostly we see in the 65 to 100 group, we see low contacts across the board. There's some notable exceptions. Something was happening in Atlanta sort of during our wave 3. This is, I think, our July wave. And you can kind of see otherwise the contacts is pretty low. So 2.5 or around 2 is very low compared to what we see in the polymod. I think the average in polymod is around 8. The number of contacts, even in older age groups, the contact is still pretty high. So 2 is actually sort of historically low. And you can really see the 65 to 100 groups probably isolating well into sort of the winter. So pretty low contacts across the board, but we see some interesting changes happening to younger age groups. So for example, in Boston, this 18 to 35 really takes off, probably with some return back to colleges, even though most campuses were still online for most of our survey wave, but you can still see this increase in contacts, particularly in the younger age groups over time. And one of the reasons that we were sort of interested in this as well, we've seen a change in the age distribution of cases over time. And you know, this is the combination of many things. One is, you know, who's getting tested has changed dramatically from the start of the outbreak to now. And so this is, you know, we would, even without any change in age contact patterns, without any change in contact patterns, we would still expect to see these changes because testing and diagnosis have dramatically changed over time. But we were interested in the question of perhaps there could be some impact of these increases we're seeing in the younger age groups over time. And so Taylor put all of our contact matrices into an age structured SEIR model, and this is the model output at each of our survey waves. So instead of just plotting out the whole thing, I'm just showing the incidence rate ratio. So what we're showing here is the incidence rate for example, if we're looking at the purple line, that's the incidence rate for 65 to 100-year-olds relative to the incidence rate for the 0 to 18-year-olds. So that's our sort of reference category here. So essentially, again, we see for 65 to 100-year-olds, the infection, this is the total infection and not clinical infection. If we're looking at clinical symptomatic cases, this picture is completely reversed. So as you might expect, the 65 to 100-year-olds actually present a lot more in terms of clinical cases. But when we're looking at overall infection burden, we actually see just based on the contact pattern that we would expect quite a bit of cases in these younger age groups. But that when we look at the clinical cases, we don't see that reflected as much. But we can see that especially in some of these groups, there's been an increase over time. And then we made an attempt to match it to whatever data we had available. It's a little bit hard to get city-specific age-structured case data, particularly over time. It's a lot easier to get that at the state level, but we managed to get it for a few cities. So we've done this for New York, Phoenix, and I think I'm not showing the results here for Boston and Atlanta, but they look very similar. But essentially, this is our proportion of cases in each age group by survey wave in our age structured simulation, and then this is the observed actual proportion of cases. So we see we match it pretty well. So even though we think a lot of this is probably over time driven by testing, it's, you know, the social contact pattern and the changes in social contact is still likely playing a big role in who we see showing up in the actual test data. Okay, so I'm going to talk very quickly about 2 other projects, and I won't go into the detail, but I thought it's, you know, since it's work in progress, and I would take the advantage of presenting to your group to see if people had thoughts, and I'd love to discuss this if we have time. But the one project the first project is by Casey Breen, who's a grad student with us at Berkeley. What he's been doing is taking our national and city specific samples and using a statistical model to estimate what contact patterns would look like for each state. And so the idea here is that these surveys are very expensive to do, and it's hard to do this for each locality, for each wave that we might want to, but really these contact patterns we know depend on local conditions. And so, you know, we don't want to put, just like we don't want to put the polymod contact matrix for an age-structured model for the US, we probably don't want to put the national US matrix as the matrix for a specific state. And so when we project this onto specific data, so we have some data, the idea here is we have some data for each state in our national sample. We pool our estimates to sort of fill in the blanks and get an overall picture of what's happening in each state. And so we can see some state level differences that we can talk about later. I won't go into the details here. But I think I lost one slide here, I apologize. But one of the interesting things we see is that if we look at the dominant eigenvalue of this contact matrix, again, that gives us a sense of the R naught. We see some big differences by state. So particularly South Dakota, Iowa, I think, were the two places that really stood out in terms of pretty high levels of contact, even sort of in the earlier waves, and especially high levels of contact in the later waves. There's interesting rural-urban differences that we're thinking about, and I think that will be sort of a next step, because even within a state, there's a lot of difference in social structure and contact patterns, and so I think that will be important to think about. And then finally, the last project I'll talk about very quickly is by Ethan Rubinoff, another wonderful graduate student with us, and Ethan is sort of interested in this question of who's able to socially distance and who's not. And so if we're thinking about what happened in the US in terms of vaccine prioritization, well, some of it went to essential workers and frontline workers, and some of it was prioritized to seniors. And there's this argument that if you're prioritizing to seniors, well, that's a predominantly white group in the US, just by the way that the demographics works out. And so there's a question of what happens if you have this hypothetical scenario where you consider a more even split between not just frontline workers, but essential workers more broadly, many of whom were not eligible in the first round of vaccine rollout. And interestingly, overall, it turns out that prioritizing seniors still makes, usually under all scenarios, makes most sense in terms of averting deaths. Even when we consider sort of the indirect effects, it's still, and we know essential workers have a lot more context, just that's what we would expect, but we also see it in our survey data. But even accounting for those indirect effects of vaccination, we still see that prioritizing seniors makes the most sense in averting deaths. And this is just presenting one scenario. Ethan's been playing with sort of different scenarios and different timing, what part of the outbreak are you in, and sort of what percentage of the economy is open, how many people are in these essential worker positions, and so on. And so this is sort of a project trying to get at different possible alternative vaccination strategies. Sort of the bottom line is, it seems that prioritizing seniors really is despite the indirect effects, seems like the way to avert the most deaths under all of the scenarios that Ethan has been considering, which is interesting because we see a much higher level of contacts in younger age groups. We also see a much higher level of contacts for adults working in person, but those indirect effects are so small, particularly because the mortality curve for COVID-19, it just increases so sharply by age that it sort of washes out some of those indirect effects. So I'll stop here. Just in summary, we're still collecting this data. We've made a lot of it publicly available. We just haven't had time to clean up the most recent waves, but our hope is to get it all out there. So, mostly so modelers can use this data. We're sort of interested in other questions, such as we want to keep doing the survey beyond just this sort of pandemic lockdown period, but trying to understand sort of seasonality and context and how much that's changing, and thinking about what's happening to other respiratory pathogens. We've seen a lot about RSV and several papers on RSV recently about the spike. And so some of that is some of these contacts are happening. It's sort of a delayed outbreak, but we see an increase in contacts, particularly in schools and workplaces. So the idea is to keep sort of thinking about these questions as we go forward. So I'm just gonna thank our funding source. Our first paper on this is out and has much more info actually about the survey. It's a very descriptive paper and less focused towards sort of modeling, but with the hope that modelers could take this data and use it. And that, if anyone would like to use this data, we really welcome it, because we've been collecting it. It's been hard work collecting it, and we just want people to be able to use it. So I'll stop there.
Thank you very much, Dr. Ayesha, for sharing with us all these exciting findings.